Acha, Assalamu alaikum everyone, and thank you for staying back. Obviously, we'll try to match the intensity and educational value of the session that preceded us. So my name is Asaad Khan. We have Osman Fahim and Ali Raza with us. So again, exactly the way this previous session was run, our plan is that we'll show you some slides, and then on every slide we'll have a discussion. Main purpose of the session is that aap log questions karenge, and then we'll try to answer them. And obviously, because Pakistan ki different, pretty much every city has a center which is doing TAVR. So we are going to try and see what are the different ways of tackling a situation that arises. So, over to you, Usman. Please start.
Thank you, and Assalamu alaikum everyone. Try to keep it as interactive as possible, and hopefully that sound won't come again. So this is a very straightforward, I think we decided that we would pick a straightforward case and just go through each one of the steps and talk about potential pitfalls and what goes well, what we do similarly, what we do differently, and then open it up for questions to everyone. So this was a recent case we did at AKU. It's a 62-year-old male. He's got the traditional risk factors: hypertensive, diabetic, obese, and he's on chronic steroids. Was seen by cardiac surgery and was turned down. He's got NYHA 2 to 3 symptoms. CAT showed non-obstructive coronary disease. And on echo, his EF was normal. His RV was normal. He had mild MR, moderate TR, slightly elevated right ventricular systolic pressures, and severe AS. On the echo, it looked like it was bicuspid, although not. It wasn't clear if it was a fused bicuspid or a tricuspid. Mean gradient was 47, and there was no significant aortic regurgitation. So at this point, I'm just...
Usman, I've got a question actually here. So I just wanted to ask the audience, what do you guys think that, what should be the age for TAVI? Or if someone has got severe aortic stenosis with you guys, who will you refer for TAVI? What age will you refer? More than 65?
Ali, there is another part to it as well. Okay. It's a bicuspid valve.
Oh, bicuspid valve. Oh.
So bicuspid and a youngish age. So how many of you will refer for TAVI?
Yes.
And how many
So bicuspid valve, 62 years age, who would refer for surgery? If you could just show the hands. Who will refer for surgery? Who will refer for TAVI? I want to know. And I'm going to write their names.
So ये TAVI वाले vote इधर आए.
TAVI वाले vote. TAVI वाले vote इधर.
AFIC से.
AFIC. TAVI. सारे TAVI. ये तो सारे PIC वाले, पेशावर वाले.
इस मीटिंग पे सर्जरी वाले कोई नहीं है.
सर्जरी वाला कोई भी नहीं है लगता. ठीक है. जी.
Dr. Usman, I have a question. What was the indication for the steroids in this patient? And was this shortness of breath related to some other disease or not?
COPD.
And what was the duration of the symptoms?
So excellent questions. His steroids, he has thrombocytopenia. I think it's ITP, and that's why he was on chronic steroids. The symptom duration was progressive over a course of 1 year. And he has obesity, so that's one reason for him to be short of breath. But generally, there was no significant lung disease or any other cause that would contribute. And on the echo, the valve was clearly stenotic.
So we have got a gentleman who was going to refer him for surgery, Usman. So you need to answer why did you not refer for surgery, okay? So
we did. So all of our patients do go for evaluation by a cardiac surgeon. And so they were worried about his obesity as well as his chronic steroid use and healing. So that was the reason that they turned him down. But to open it up further, let's say the surgeon said that we'll operate.
Okay,
right?
Let's say the
So
surgeon says we will operate. I asked them the question, which stent are you going to do, mechanical or bioprosthetic? If he tells me bioprosthetic, I just tell him, okay, fine, I will send it to you, and then I just never call him. I just don't answer his phone. So then, if it's a mechanical he's going to do, and there is a aortopathy, then yes, probably yes, but What would you guys do? Would you guys refer to surgery if they say yes?
No, so it would be a discussion, I think, a heart team discussion. So the important thing, especially in bicuspids, is to remember the cutoff is 45 millimeters. So if you're going to operate on the valve and the aorta is 45 millimeters, then you consider doing a root replacement as well, or a root repair. I completely agree with you that there's no benefit to a surgical bioprosthetic AVR in a young patient versus a TAVR valve. And so, unless they're going to do a mechanical valve and the patient is committing to warfarin for the rest of their life, I would prefer for them to have a bioprosthetic TAVR valve.
I just want.
My question is that if you think of the whole life of the patient, so doing TAVR here, even if a bioprosthetic, would the second time doing TAVR, would that be better, or do a TAVR here and then 10 years later do a TAVR again?
Okay, so 3 points that I want to answer this with. पहली बात तो ये है सर कि पाकिस्तान की एवरेज पॉपुलेशन इज 67 years old, उनकी एज है, तो ये पेशेंट इज ऑलरेडी 62 and has multiple comorbids. Second issue is कि what the data they have for TAVRs versus TAVR in terms of degeneration. तो what we know is कि जो gradients आ रहे हैं after 7 or 8 years वो TAVR valves के कम हैं for surgical valves and for multiple reasons कि we get a bigger valve area and everything. और third question जो आपका है कि इस स्टेज पे TAVR कर दें बाद में TAVR, तो एक चीज़ तो अफोर्डेबिलिटी है, बट इफ अफोर्डेबिलिटी को हम निकाल दें, वी आर टॉकिंग अबाउट एन आइडियल सिनेरियो, तो अब जो कॉन्सेप्ट्स हैं कमर्शियल अलाइनमेंट के, इफ यू आर प्रोटेक्टिंग द कॉर्नी ऑस्टिया एंड स्टफ, यू कैन डू अ valve in them as easily as you can do a TAVR. I don't know.
Yes, agree.
जहाँ तो सेपियन हो रहे हैं वहाँ तो whether doing TAVR in TAVR after an evolute is more suitable, is more appropriate, rather doing a TAVR and then an evolute.
तो इसीलिए कमर्शियल अलाइनमेंट कॉन्सेप्ट इज मेनली फॉर कोर वाल्व ना, वो तो सेपियन इज बिलो द वाल्व.
सो असद ने जो बात की सर कि आपकी बात 100% ठीक है. अगर आपके पास बलून हो तो जिस तरह असद ने भी किया कि हाँ वो ठीक है सर, आप पहले बलून कर दें, अभी बलून वाल्व सेपियन कर दें, इसके बाद आप इसको TAVR कर दें सेल्फ एक्सपेंडेबल. लेकिन दूसरी बात, आई एंडोर्स दैट कि कमिश्नर अलाइनमेंट, और अब हम लोग इतने सोफिस्टिकेटेड हो गए हैं कि वी कैन डू इवन अ बलून सेल्फ एक्सपेंडेबल इनटू अ सेल्फ एक्सपेंडेबल.
और हाँ,
इस पेशेंट में जो कि you said that he's got ITP and he's on steroids, and if this patient is taken for TAVR and that to mechanical, so would there be any issue or problem with putting him on anticoagulation in a situation like ITP?
that's probably another reason to go for TAVR.
Yes, that's. I think there is no surgeon here, so very good point.
That's why Simor Saab raised his hand before everybody.
That's why we don't let them into the TAVI meeting.
There's 2 issues with the ITP. So one is heparin during the surgical procedure and risk of further dropping of the platelets. The second issue is long-term oral anticoagulation. That's fairly well tolerated as long as the platelets are over 50,000. But the risk of platelets dropping further, because the surgeons give, I think, 18,000 of heparin during the procedure. We can do ours with much less heparin. So those are the 2 issues with the ITP. Thank you. All right. So moving on, I think let's talk a little bit about pre-procedure planning. Just like any other procedure, I think the attention to detail and looking at all the patient factors yourself really matters. This is the report that you will get from the company, whether that's Medtronic, Edwards, or Boston Scientific. And so, Asaad, what do you look at? I think all of us look at the CT scan ourselves, and we do all of our measurements, but this is the report you get. So what do you look for in the report?
When we were doing that training village session, our emphasis was that 70% of the case is essentially your CT TAVR assessment and planning. And मेरे ख्याल में हमने 5 मिनट सिर्फ इसी चीज़ पे लगाए थे to emphasize the fact that no radiologist can actually tell you how to proceed with this valve unless you get an understanding of what you're going to do with it. और हमारी भी यही practice है अपने में भी और wherever we do it in AFIC and stuff कि हम हर case से पहले we look at the CT ourselves and we analyze it ourselves. तो again just to second your point कि CT के assessment is paramount and we have to do it. Question number 2 कि आप देखते क्या हैं? तो कल question was in the training village, the question was कि आप area देखते हैं, आप perimeter देखते हैं या minimum diameters देखते हैं. So what they have found is कि the biggest valve area that you get is by perimeter, and then you get area, and then after that is diameter based. So for core valve and the self-expanding valve, जो Boston का भी है, इसके लिए भी we go by perimeter, or for the balloon expandable valve we go by area, because balloon expandable में अगर आप you oversize it too much, there is a high risk of perforation versus a self-expanding valve, जिसके अंदर there is a low risk. And then again for all these parameters, I'll get everybody else to speak as well, but all these parameters have to be in line. जो question आता है वो tight sinuses वाले question में issue आता है, क्योंकि एक question जो कल भी actually परसों जो हमारा structural का session था उसमें question मुसलसल आ रहा था कि what is the cutoff for coronary heights, और उसका answer was given very nicely by Gilbert Tang कि it's not just one parameter, और वो जो cutoff था that was for sapien. Core valve के there is no one cutoff, हाँ कि आप you look at the sinus heights, you look at the sinus width, you look at the coronary heights, everything in combination gives you an idea whether you should do it or not. I don't know.
Yes, I agree with that. मेरा एक और question ये कि कितने लोग हैं जो CT स्कैन से, क्योंकि इंटरवेंशनिस्ट आप जब होते हैं, कितने लोग हैं जो CT स्कैन गए हैं कुछ महीनों के लिए, हफ्तों के लिए सीखने के लिए अपनी ट्रेनिंग में? फेलोज मैं पूछना चाह रहा था. अच्छा, 1 2 3 4 सलमान का तो मुझे पता है 4. और तो ये इशू क्यों है? देखिए मैं आपको एक बताता हूँ, क्योंकि जब हम लोग ट्रेनिंग होते हैं ना, क्योंकि मैं जब शुरू में FCPS पाकिस्तान में उस टाइम मुझे पता था कि ट्रेनिंग किस तरह है और बाहर किस तरह थी. बाहर आपको अपॉर्चुनिटी, आपकी 6 months रोटेशन होती थी, तो हम ऑलरेडी फेमिलियराइज हो जाते थे इस तरह. मेरे ख्याल में उस्मान और असद दोनों का ही इस तरह होगा. आप लोग जो पाकिस्तान में ट्रेनिंग करते हैं ना, प्लीज़ स्पेंड टाइम इन CT. आने वाला वक्त इंटरवेंशनिस्ट का ऐसा ना हो कि आखिर में फिर आपको उसमें पैसे बनाने पड़े सिर्फ CT स्कैन में, क्योंकि एंजियोग्राम ख़त्म हो जाए. तो छोड़े इसको मत, CT स्कैन जाएँ सीखने के लिए, ठीक है? तो ये बहुत ज़रूरी है, और ये TAVI के लिए पैरामाउंट इज CT स्कैन आपको आना चाहिए. तो बगैर, अगर आपने फ्यूचर में TAVI स्ट्रक्चर का कोई भी प्लान करना है, तो जो फेलोज हैं प्लीज़ फेमिलियराइज योरसेल्फ विद द CT.
So if you look at this patient, so generally when you start worrying about coronary heights is at 10 millimeter for all the valves. So if you look at left coronary height is 9.7 and the right is 19. So right is pretty high, and typically in bicuspids the right tends to be high and at times might be a little bit anomalous. But when you look at the 10 millimeter, then the next thing you're looking at is the sinus depth and the sinus height. So a coronary can be very low, but as long as your sinuses are deep, which is this measurement horizontally, there is still room behind the valve for blood flow to get into the coronary. And also the STJ height matters, because the higher the STJ, there's going to be blood that flows down and into the coronary. So the coronary can be low, and you don't have to protect it or worry about coronary obstruction. But a lot of times, and especially small women, you have effaced sinuses. So not only the coronary is low, but the sinus depth is small and the STJ height is also small. And that's when you start planning for potential coronary obstruction and different techniques. And so these three measurements are critical for you to understand how the valve is going to sit and what the coronary flow is going to be like post-valve deployment and future coronary access as well. So the other thing we talked about was the perimeter and the area, and generally for self-expanding valves you want to oversize by about 20%, and for balloon expandable valves anywhere from 10% to 15%, but definitely not more than 15%, because as Asaad mentioned, you run the risk of annular disruption. So, the other thing you get on the CT report, and which you should be looking at yourself, again, the sinus depth, leaflet calcification. So, Ali, how do you kind of look at leaflet calcium, and do you worry about its distribution? Is it a friend or a foe?
Yes. So things because if it's a bicuspid valve, remember this, that the calcium, Okay, so calcium is your friend to some extent because without this you will not be able to do the TAVI. If it's a bicuspid valve and the leaflet is calcified, raphe is calcified, that's your enemy actually. Too much nodular calcium or anything around that area is your enemy as well. So calcium, you have to be like a friend. इस तरह cardiac surgeon की तरह है. उसको करीब भी रखना है लेकिन ज़्यादा उसको जगह भी नहीं देनी ना. इस तरह की जगह है. Calcium आपका cardiac surgeon है. ठीक है. जो आपका दुश्मन भी हो सकता है और दोस्त भी हो सकता है. तो कैल्शियम को आपने बड़े तरीके से डील करना है. इसलिए आपने इसकी क्योंकि इट विल हेल्प कि आपने प्री बलूनिंग किस तरह करनी है, आपने उसको अपने वाल्व डिप्लॉयमेंट कहाँ पे करनी है. तो this is the first thing to look at when you are starting your procedure. So start with the calcium looking.
अच्छा, couple of things. For bicuspid valves, remember कि जो जितनी measurements हैं, जितने भी आप courses पे जाते हो, जो standard measurements हैं for sinuses, for corny heights and stuff, they are for the tri-leaflet valves. जो bicuspid है ना, remember कि ये दो दरवाजे हैं जो तीन का काम कर रहे हैं, तो they are bigger in size. और तीसरी चीज़ ये कि दो दरवाजे जो तीन का काम कर रहे हैं, जो flow turbulence है उनमें वो ज़्यादा है as compared to a tri-leaflet valve, क्योंकि ज़्यादा ज़ोर से खुलते हैं, they're heavier and stuff. इसलिए इनमें जो calcification है, that is also mostly heavier than what you usually see. और तीसरी चीज़ और आखिरी चीज़, sorry, वो ये कि there are two things for bicuspid valve which has shown कि in patients में अगर आप करोगे तो इनमें there is a higher likelihood of a complication on the table as well as afterwards as well, just like things like paravalvular leakage and stuff. One is obviously the calcification जो अली बता रहा है कि अगर बहुत heavy है LVOT में, और secondly जो main मसला है वो आपका रैफे का. If your रैफे क्या है, I don't know if everybody is aware of it, कि रैफे essentially is the joining point of the two leaflets. Either it's physiological or functional bicuspid, जहाँ पे essentially originally it might have been a tri-leaflet valve, लेकिन अब वो bi-leaflet हो गया और उसकी जो tips हैं they are connected with the calcified spot. जिस तरह इस केस में कि इस केस में the entire raphe is not calcified, it's just a spicule of calcium which is sort of hugging that part which was supposed to be separate. तो इस किस्म के केस में where the entire raphe is not calcified, it's a pretty pliable valve for balloon valvuloplasty, and then you can deploy it. If that entire raphe was heavily calcified, probably I won't do that valve. I don't know what the others would do. Huh?
Just a question regarding the coronary occlusion concern, apart from the coronary height and the sinus width, routinely to nahi use karte, but any role of leaflet length, measuring that, some people measure that, and the other thing is the difference between sinus और उसका coronary height का difference measurement करके उसका भी कोई number कुछ लोग use करते हैं. And do you guys consider that?
Bicuspid में again we use the leaflet length as well, especially if it's a tight sinus. Luckily, जिस तरह उस्मान ने शुरू में कह दिया कि bicuspids usually are associated with a wider aorta than normal, तो उसके अंदर we get away with it. लेकिन because it's a bigger leaflet, तो what I look at is the leaflet tip calcification, because what you are assuming is कि जब आप valve लग जाएगा तो leaflets are going to stand up like that. So if the corny heights are low, leaflet की tip पे calcium है और sinuses भी tight हैं, ST junction भी low है, तो maybe these are the cases where you need to worry about corny occlusion.
मेरा एक और ये है कि आप लोगों को कितने लोगों को लगता है कि भाई ये इमेजिंग कंसल्टेंट का काम है और कितने को लगता है ये इंटरनेशनल कार्डियोलॉजिस्ट का काम है? बिकॉज आई कैन सी सबा स्टैंडिंग देयर. अब्दुल हकीम कहते हैं ये इमेजिंग का ही काम है, ये आप लोग इसमें उंगलियां ना मारो क्योंकि उसकी तो वाइफ इज इमेजिंग कंसल्टेंट विद हिम ना, तो इसलिए सबा कैन यू प्लीज, actually I've got this question. How much do you think that the interventionalists should learn CT imaging? How much, or do you think they should rely on the radiologist?
I think I 100% agree with what you and Usman said. The interventionalist absolutely has to look at the CT themselves. I think it's the same for any kind of structural procedures. If you don't know what you're looking at on TE or on CT, then I'm not sure how you can be doing these procedures. So some degree of familiarity is extremely important. Now, you may not necessarily be the official reporting person, or you may need two sets of eyes. Maybe the imager also reports it and the interventionalist also looks at it, or the other way around, but you definitely need to have some degree of familiarity looking at the sizes, the ostial heights and things like that. And I've actually been encouraging our surgeons to start looking at things, because more often than not they've actually never looked at the echo, and then they're getting ready to do a TAVR and they don't really care because they're like, we'll look at it when we're in there. I said, no, you should really come and look at this. And so now they've started to come by the echo lab or, to come to the valve clinic where we have the echo machine and start looking at the images. It makes a big difference in how you can pre-plan your procedures, what to expect, and then it takes away sort of the blame game later where you say, well, you never told me about this or you never told me about that. So I actually like it when the interventionalist stops by and actually looks at the study either with me or looks at it on their own whenever it's convenient for them, so that later on there aren't any surprises for anyone.
Thank you.
And the other thing to remember is that you're getting a chest, abdomen, pelvis CT, and occasionally you'll find something that the patient didn't know about, and that's an important thing. So do look at the radiologist report as well. The other things on the CT, look for the LVH and the LV size, because your wire position is going to matter. How much septal thickness there is will affect your valve depth and valve positioning. And your STJ calcification and annular calcification. The STJ calcium matters when you're doing a BAV, if you're doing a BAV, because you can disrupt the STJ and dissect the aorta. And annular calcium, if it's heavily calcified circumferential calcium, then you may not want to do a BAV, and it may affect your choice of valve. I think Ali, there's a question.
इसमें आपकी जो लेफ्ट कोरोनरी हाइट इज़ 9.7, इसमें कितने डायमीटर जो साइनस की डायमीटर है इसमें तो बड़ा अच्छा है, लेकिन आप कितने अनकंफर्टेबल होंगे? लेट्स से अगर 24 है
जो recommended
would you be comfortable
if all the other numbers are within the recommended limits? And for a bicuspid, as we said, we always measure the length of the leaflet as well. So if they are all okay, और इसके अंदर जो left वाला है उसकी टिप पे थोड़ा सा कैल्शियम है and it's nothing major, so I think this is a pretty doable case. नहीं, लेंथ ऑफ लीफलेट इज रिलेटिव ना. अगर कॉर्नी हाइट भी छोटी है, एसटीजे भी कम है, साइनसेस भी टाइट हैं, और फिर लेंथ ऑफ लीफलेट भी और जो द वे आई वाज टॉट वाज के ऑन द सीटी वंस यू हैव गॉट योर एनुलर प्लेन वी मूव अप एंड डाउन, एंड एट द लेवल वेयर यू सी द कॉर्नरीज, अगर उस लेवल पे भी लीफलेट नज़र आ रहा है, बिकॉज यू रिमेंबर यू डू द सीटी एनालिसिस इन मिड सिस्टली जहाँ पे लीफलेट पूरा खुला हुआ है, तो इफ एट द लेवल ऑफ द on your aorta, the root of aorta, जब आपको corneas नज़र आती हैं उस लेवल पे भी अगर आपको लीफलेट नज़र आ रहा है, तो that means there is a chance it will come in front of it.
साइनस जो आप कह रहे हैं कि टाइट हो, उसकी कट ऑफ क्या है?
जो लिमिट है हर वाल्व की है ना,
जी, हर एक वाल्व की डिफरेंट है कि सपोज कर लेते, लेकिन जिस तरह असद ने भी कहा सर, इसमें कोई हार्ड एंड फास्ट रूल नहीं है. अक्सर आप प्री बलूनिंग के साथ देख भी सकते हैं, बहुत रफ आइडिया है, इस पर रिलाई मत करें, लेकिन इट कैन हैपन कि आप प्री डिल कर रहे हैं, उस टाइम आप एओटोग्राम करें, देखेंगे वो करते हैं. लीफलेट्स की हाइट अगर आपकी STJ तक पहुंच रही है सपोज करें, या जिस तरह असद का सामने आ रही है, तो अगर ये STJ तक लीफलेट्स आपके पहुंच रहे हैं, तो मतलब ये अब कुछ भी फ्लो नहीं जाएगा उसमें साइनसेस में फिलिंग के लिए डायस्टली के टाइम. तो ये 2-3 चीज़ें, लेकिन इससे आप प्रोसीजर से नहीं रोक सकते. आप चिमनी टेक्निक कर लें, आप अगर वाल्व है तो उसको पिज़ेले का कर लें, रोकेगा नहीं आपको प्रोसीजर इसके लिए, सिर्फ कंसिडरेशन के लिए.
So the company IFU will give you recommended values for all of these, for sinus depth and STJ height and everything. So you take that into account in your final decision. And if you look at this case, so that's the left coronary and it's visibly low. Now if you just look at the leaflet height or length, and you imagine that the leaflet is going to be pushed over when the valve goes in, it looks like the leaflet will obstruct the coronary. But then you look at this sinus depth, and so there will be room behind that pushed back leaflet for blood to get into, and the STJ is high. So even though the leaflet is going to end up somewhere around here, the blood will be able to come behind the stent of the valve and still fill the left main.
Just one excellent, और यही that was my point as well. So once you look at this leaflet, तो फिर अगली चीज़ देखते हैं इस leaflet की calcification कितनी है. हाँ, if it's all heavily calcified, तो what you're assuming is that it will keep standing up once the valve is implanted here. Whereas a soft pliable valve like this will probably fold down and fall under gravity as well.
Exactly.
So if you have room in the sinus, it will fall. But if it is calcified, everything is tight, so again that's a consideration that you might end up with a cornea occlusion.
Do we measure the leaflet size in order to determine कि वो leaflet मतलब कितना है, उसको space चाहिए या नहीं? That is not important.
People do. Go ahead.
People do that. I think that I think we are thinking about the leaflet height too much at the moment. I think leaflet height is just a rough measure with the rest of the things. Like ये आपका supportive है उसके साथ. Leaflet height पे मैं अपना decision, I wouldn't base my decision, I think,
Exactly.
on the leaflet height.
Yeah.
Whatever leaflet height is, like Asad mentioned, fly, it will fall down, sinus is big enough. अच्छी बात ये है कि बाइकस्पिड में अक्सर साइनसेस आपके बड़े ही होते हैं उसमें ज़्यादातर थोड़े बहुत. तो ये है कि आपका लीफलेट की हाइट की वजह से आपको इतना डिस्टेंस फर्क नहीं पड़ता.
So the other thing that and I think this question came up day before yesterday also, is the intercommissural distance and the minimum and maximum diameter. So with bicuspid valves especially, there is this constant debate: do you size to the annulus or do you size to the actual orifice area? So I generally tend to size to the annulus. I don't know, Asad and Ali, what's your practice?
I go by annulus as well.
Yeah.
Yeah, I do it unless and until it's a borderline. Then I go to move to this. And then what I do, I tend to downsize the bicuspid valves and I tend to upsize the tricuspid valves. I don't know, is that okay, isn't it?
I try to get 15 to 20% oversizing for all the valves, whether they're tricuspid or bicuspid.
Because
and that's, we'll come to that in this case also because it wasn't.
I think मेरा क्या ख्याल है, देखिए जी कि bicuspid जो valve है ना, that will always end up a bit of a fish mouth type. It will never become circular. आप जो कुछ भी कर लें ना, तो ये रैफे तो आप उसको खोल तो नहीं सकते हैं, ये कभी भी स्प्लिट नहीं होगा ये रैफे इसके लिए. तो इसीलिए अगर आप सपोज करें, स्पेशली अगर इट एंड्स अप टू 34, फिर तो मैं थोड़ा और भी वो हो जाता हूँ, कॉशियस हो जाता हूँ, क्योंकि 34 में इन फोल्डिंग का चांस ज़्यादा होता है फॉर दीज वैल्व. सो आपने ये बहुत ख्याल रखना है कि अगर 34 पे आप जा रहे हैं तो मेरी तो सजेशन ये कि डाउन साइज इट इफ़ इट्स इन द बॉर्डर लाइन कैटेगरी. एंड जिस तरह उस्मान ने कहा कि ऑब्वियसली इफ़ यू हैव टू अपसाइज, डिपेंड्स ऑन how you feel about that valve, how much it's going to open and the way.
So infolding is important because it affects your leaflet opening and there will be theoretically more rapid, either acute problem or progressively more rapid valve tissue degeneration because the hemodynamics are not lamellar.
ये 34 में इनफोल्डिंग का चांस क्यों बढ़ जाता है?
Oversizing की वजह से.
Also के 34 के जो strength है, radial force वो सबसे ज़्यादा है, तो वो it's going to push out in a very abnormal way in a fish mouth sort of a valve. और overall ये जो भी recently जितना data आ रहा है 34 valves का, उसके अंदर mortality भी ज़्यादा आ रही है, pacemaker rates वैसे भी in general थोड़े से ज़्यादा आ रहे हैं, तो maybe that's why probably you go with a 29. और lastly 34 does not have an external skirt जो कि 29s में है, तो you have a better chance of sealing it. हाँ, प्रो प्लम्बर हम अपनी बात कर रहे हैं ना. हाँ,
अच्छा, रिगार्डिंग ओवरसाइजिंग सेल्फ एक्सपेंडेबल में, जैसे आपने कहा बलून एक्सपेंडर में देयर इज़ लिमिट 15% से ज़्यादा नहीं कर सकते, तो उसमें कोई लिमिट है 20 से ऊपर या कितना कर सकते हैं?
So generally self-expanding you want oversize about 20%. You want it to be a little oversized. And balloon expandable you want to keep the oversizing less than 15%.
क्योंकि self-expanding is going to anchor based on its radial strength. ना उसको आप कम oversize करेंगे, it might not fit there. और हाँ, यही मेरा ख्याल है.
So Abdul Hakim, because we commented on that as well, and I think oversizing and undersizing for the bicuspid, what do you think?
See, it comes down to where you're measuring. Okay, so if it's a bicuspid and it's calcified, understand your anchoring point, if you're going to use the cusp overlap technique, is the leaflets itself. So if your annulus, say the perimeter is 86, and you're thinking of a 34, but if you go to the intercommissural distance at 4 to 6 millimeters above the annulus, and you're getting an ICD of say 23, 24, a 26 valve is good enough. So you have to be very careful because, you know, with bicuspids, the anchoring point is not the annulus. Because if you put a 34, it's going to be so constrained, you can balloon it all you want. It is not going to. I think I had a case that I had shared with Osman where we had like a very, very horrible kind of enfolding. Same thing, it measured 34, I was like, okay, we'll put a 29. In that patient, if you even put a 26, would have been okay. All right, so you have to see where, bicuspids are a different animal. So sizing, it's still a matter of debate. I know where Osman trained people at TL think, just go by the annulus. But I'm telling you, it has to depend. Is it a flash shape? Is it a box or is it a reverse flash? Those are three phenotypes. So you have to keep that in mind.
And so this patient's measurements actually came out right at the upper end of a 29 millimeter valve. So his perimeter is 79, and the upper cutoff. Oh, sorry.
Okay, Dr. Noman Nasir makes a very good point. He says, what if you have an annulus, an ICD, that is more than the annulus? What do you do then? Do you size according to the ICD, or are you going to size according to the annulus? That is a very good question. What do you think? I'm not going to answer that. I'll give you my answer at the end.
Can you have an ICT larger than the annulus? I don't know.
Now, the question is where you're going to deploy this valve. For bicuspids, I deploy very high actually. Even at -1 probably. If I don't have to post till and I make my mind before that, then I size according to that. If I'm going down to the annulus and I'm going to deploy it a bit deep, I'm not sure, that's a very difficult question. Then I think it will depend on how my mood is that day. So I think for a higher implant, I will still go with intercommissural distance. And I will deploy it higher actually, because this will never reach the annulus. I personally think, I might be not that right, I don't have any evidence with it. Bicuspids, like you said, it's a different ball game altogether. Their contact with the annulus is not that much actually, because this valve does not even open that much actually. It never becomes circular. It will never take the shape of the annulus or the measurements of the annulus. I don't know what's the other people's opinion about it.
Yeah, especially for self-expanding. The balloon expandable, you can kind of force it to conform to a circular orifice. But that also raises another point where you have that cusp overlap view and the 3-cusp coplanar view. And recently we've moved towards more and more cusp overlap view. But in bicuspids, that's always a challenge because you don't have 3 well-defined cusps. And so what we had in this patient was a near cusp overlap view where the non-cusp is isolated and the lowest and the right and left are overlapped, but not completely so. But look at the angle, REO 14, caudal 32. That's a tough angle to be working in. And an obese patient, you would not have good penetration and good imaging. So then sometimes you have to fall back to your traditional 3-cusp coplanar view.
He wasn't that obese. He was 80 kilos, Usman. What are you saying?
Quite short.
Says Ali, who's heading there.
So how do you guys use these two views in your practice?
I think for bicuspids, you always end up using a near cusp overlap view. And actually, REO caudal, I was thinking that it's acceptable. What we usually get is 50s and 40s. वो वाले तो you can never achieve, but maybe 30. For the final deployment, obviously, you cannot do the entire procedure in it. And ये जो Medtronic की standard practice guidelines हैं, what they want you is to start in the cusp overlap view, and you always check in your LAO view before you decide on the final deployment. So you have to achieve this angle for a very short amount of time, or I think this is pretty doable. So I will probably start with this one and then move to the LAO.
Yeah.
If you do cusp overlap as standard practice, तो भी यही है.
And the reason for pushing for cusp overlap is because it really allows you to not be very deep and minimizes your pacemaker rates. All the data has shown that your pacemaker rates really go down with cusp overlap.
Because every 10 degrees LAO, you are probably 1 millimeter deeper actually. So that's the rough calculation for it. So LAO will always give you false impression that you're high, but you will be deep. And you don't want to reach the muscular part of the septum because you don't want to press on the left bundle there.
Let me ask you this, Usman. For balloon expandable valves, have you started using cusp overlap?
No.
No, you still keep it in the right coronary and you go to the 3-cusp view.
Yeah, and generally the valve, as you know, foreshortens a lot from below. So it's less likely that you'll end up very deep. And typically, you end up deploying about 80-20. And with the ceiling skirt, you're less worried about leaving significant PVL also. So that's why the pacemaker rates have been lower, and I think the 3-cusp view works pretty well for balloon expandable so far.
Now you know that Samir Kapadia published his series using the cusp overlap view for balloon expandable valves, and I think his pacemaker rate was like 2-point-something%.
Yeah.
No, I agree that it foreshortens from below, right, south to north. So yeah, I've never done it, but I was just wondering what your thoughts were.
I think it's pacemaker rates with the balloon expandable already around 5% or so, so pretty low. And then, I mean, there's no harm. I don't think there's anything that really requires you to use 3-cusp view for balloon expandable valves. You could always switch it. So we could move on to the access, and this patient's access was very good. You know, those days are long gone of iliac on a stick and all of that stuff. We've seen those slides. Now, generally, we're pretty aggressive about going through smaller and smaller vessels, and what you're going to look at is not just the vessel size, but the calcium, the distribution of calcium, and how circumferential it is. You could have a large enough vessel with circumferential 360-degree iliac or distal aorta calcium and run into issues. And you could have a small vessel with not a lot of calcium. So we, you know, even with 4-millimeter vessels with no calcium, I'm fairly comfortable going transfemoral because the vessel will expand and accommodate your 14 French equipment. Asad, any thoughts about access?
I think that was the exact point we made in our training village session yesterday as well. Okay, it's probably the calcium which makes it non-stretchable. But one thing which I would say in addition to it, कि अगर आप 4 or 4.5 millimeter vessel में 14 French sheath डाल रहे हैं, तो you have to be very quick with the procedure because even though it will stretch, it won't cause a dissection, लेकिन there is no flow flowing into your leg. तो आप डाल के फिर बैठ के सोचने का टाइम नहीं है. You're going to do all your other homework before it, but you're just going to go up and deploy with it. और उसके अंदर it's better you pass the sheath first instead of going straight with the valve, so you make sure that there's no obstruction to it, and it also stretches the vessel a bit before you go up with the inline sheath.
Yep.
We've got, I think, very little time left. I think 13 minutes, so we will move.
All right. So basically, we went with a 29-millimeter valve in this case. Around the perimeter, we were just at the cutoff of 29 and 34. It's a little bit less oversized than I like to be, but the jump to 34 with 35% oversizing was just a little too much, and I was worried about infolding.
Just sorry, one last minute. Just go back one thing. So the standard recommendation is that if you are on the borderline, let's say that this area was 81.7 exactly, so then you go by sinuses. If it wasn't a bicuspid valve, a tri-leaflet valve, if the sinuses are wider, then you can oversize the valve. If the sinuses are tight, then you go with the undersized valve. That is the standard guideline by Medtronic.
Yeah.
This guy has great sinuses, like minus 34. Would you go 34?
No,
I wouldn't.
But it's still not on the borderline. I think it's still pretty good, and it's a bicuspid valve. So bicuspid probably sort of on the underside.
Yeah, if it wasn't bicuspid, I would have gone at 34.
I would say so.
So we use, we don't have micropuncture, unfortunately. So we use a poor man's micropuncture. We put in a 4 French sheath, dilator, and take a groin shot just to make sure.
You're using ultrasound on all your axes?
Almost all of them. Not all of them, but...
Why almost?
Sometimes the axis is just, really well-defined. You look at the CT and the bifurcation is quite low. There's not a lot of calcium or any issue.
That's Osman's experience, okay, because he's a very experienced operator. My issue is that if you don't enter for a pro glide at 12 o'clock position, this pro glide will cause you problems actually, because I would recommend that whoever starts should always go for ultrasound guide access, because once you get an experience, then you are confident, and then you're obviously, because once you reach Osman's level of experience, then obviously you can take these leverages, but not in the beginning. I think in the beginning they should all start with the ultrasound guided access. Agreed, isn't it?
Not just for TAVR, but for
everything.
It's good to have that, because you will run into cases where the access is difficult, and then if you're facile with ultrasound, it is very helpful.
For trainees, I would say that take your all femorals with ultrasound guided if it's possible for you.
Yeah.
And a shortcut to micropuncture is use your radial axis sheath. Okay, your radial axis needle, use that.
Yeah.
That's a lot more forgiving. And yes, you can then put your 4 French sheath in, but for axis.
Can 4 French, that wire which we use for the radial, 4 French goes through the, it should go through it, is it? It is okay, is it? My only issue with the bigger patients is the wire of that radial sheath, because it kinks on you when you press on it. So that is a good idea for those patients.
Yeah. And the 4 French dilator doesn't take a 5 or 6 French sheath wire. So you have to use a 4 French wire, upsize the sheath. So it is a bit of a step. We don't use a protection wire or a thing. I don't know if you guys use a...
We have stopped doing it.
Yeah. And so this is us, you know, so putting a pigtail in the non-corny cusp, and we have a pacemaker in. I know, Ali, you use the LV wire for pacemaker.
I use in my center, I always use LV wire for my things. If I'm proctoring, depends on the station there, if they are happy to use the LV wire. But I'm big favorite of LV wire and not temporary wire pacing.
Yeah.
Because for self-expandable valves, usually this is enough. I think for balloon, it's a different, because you want to rapid pace it at very end, you don't want to miss it. For those as well, you would be okay.
So if a patient gets a heart block, then you get venous access, and then you put.
So what I do is that I put a small wire in the other femoral vein, and it is just there. And through that, I complete the circuit as well. So I don't do the needle in the skin. I already put a small wire in the femoral vein there, and it is there. If I need any access, I just put a sheath in and go through that.
And so we took our cusp overlap view and the 3 cusp view. The 3 cusp view wasn't great. And so before we do a BAV, we do a BAV for all our bicuspids. And I'm curious what you guys do you do a BAV always or not for bicuspid valves? You always want to check the loading of the valve. So what do you guys look for? Ali, Asad, what do you look for?
Same. So just one extra thing. Was it hard to put the temporary wire in? You have a multi-purpose, or is it JR?
Yeah, so it was hard. It was difficult. So we use a JR guide to kind of get us up to the RV, and we just put a wire.
We used to do that with when you have a tricuspid valve implant or something.
Yeah.
We used to do the same thing. So again, regarding the thing, so loading, we were talking about it yesterday. You go on really high mag, you make sure that जो आपका valve की spine है, that should not be on top of your spine. So perfect. और तीसरी चीज़ के the 3 things that we were going to see, के these are the 2 handles of the valve that you're looking at them. So the bottom parts of the 2 handles should be at the same height. The distance is के अंदर, you see a sliver of gray here and here. That's the distance between the 2 handles and the main shaft. So that should be equal. And then the third thing should be, there should be no infolding of the valve structure on this. I don't know if there is anything additional you guys see.
Yeah, so basically the paddle should be symmetric, the valve should be symmetric, and there should be no bending of it. And look at the nose cone and make sure the sheath is almost all the way to the nose cone. And then the L-shaped hat, that position you need to keep in mind as you're going up and over with the valve. So we did decide to do a BAV, and so Ali, do you bicuspids always do a BAV?
Always. That's like a mandatory thing for the bicuspid for me to do a BAV, because I do not want to post till bicuspids too much, because I go for a higher implants at times and I don't want it to pop up out actually.
Yeah. Okay, somebody had a question. And so what's your starting position usually? Hakeem, how do you, where do you position the valve when you're starting? Are tricuspids the same as bicuspids? How do you use your pigtail?
So typically, if it's tricuspids, I would really start releasing the valve when we're really at the midpoint of the pigtail, because what that does is that brings your sheath really at the annulus, right? So you look at the valve inside and you look at the sheath. So if you start doing it right there, now if you are to really start with the valve at the annulus, you're going to go deep. So it's best to start really at the midpoint of the pigtail and start releasing.
Okay. So this patient, I'm showing the second deployment. The first one, we started off at the middle of the pigtail, and the valve was too high. And in fact, we waited. It looked okay, we hadn't deployed it, but we waited and took another shot after 5 minutes, and it had slightly inched up a bit. Now, whether that was tension in the system or something else, we were just uncomfortable. It was too high, so we redeployed it here. Thoughts on the wire position? I know they say pull the wire back and everything, and we tend to pull the wire back, although I'm not as aggressive about pulling it back as maybe some other operators.
See, I think for me, it's the...
So I think the wire is, yes, I control the wire as I go in it. So I push and pull according to that, actually. I keep it just probably in an appropriate position at the beginning. And then, because this was with the old valves. I think the new valves don't move that much in anyways now. And probably the FX, the new version of this Medtronic, that doesn't move at all, actually. So.
And for me, the valve pushing and pulling also depends on how your valve is lying in the aorta. If it's hugging the external curvature, maybe you should probably pull the wire back a bit. And then if it's sort of hugging towards the inner curvature, then you push it a bit. But again, you should always be looking at the tip of the LV and see the position of your wire. Because as we discussed in the training village yesterday, it's this transition of the soft part of the wire and the stiff part. So remember, this part is very stiff, but if you check up till here, it's pretty soft. So this soft part of the wire and this junction of the soft and the hard part is the pressure point of this entire delivery system on your LV apex. And if you look at the LV apex in a two-chamber view, apical two-chamber view, you'll realize that even if the ventricle is like really thick, the apex is pretty thin. So this is the point you really need to control. As Ali is saying, you're continuously looking at it when you're going up with the valve and controlling the position for it.
And this is where you want to coordinate with your second operator as well, because they will be able to tell you how much tension there is in the system. And the wire shouldn't be too deep because it will push the system up. And you want to rotate the catheter a little bit to make sure that there's not a lot of angulation, because that will affect your positioning of the valve, and it may pop when you release it, when that tension is released.
And last thing, the commissural alignment that we were talking about. So this is more like a cusp overlap, near cusp overlap view, because you see the LVOT is very horizontal. So they probably started with the near cusp overlap view. It's sort of more
it's a near cusp, yeah.
It's RAO and probably caudal as well. So this is the cusp overlap view. So just go back one slide. So this commissural alignment thing that we were talking about, when you're talking about future TAVR and TAVR and stuff, then you're looking at this hat marker. So for cusp overlap view, what you're looking for is that this hat marker, the thicker part, so this is the thin part, this is the C mark. This C part should be in front. If it's in the front, you have an 85% predictability that your left, the commissure will not end up in front of your left coronary artery. Right go up, right के ऊपर बहुत low है variable, ये predictability क्योंकि variability is very high. Or for the regular tri-leaflet view or the annular view, this thing, the C part can end up usually on the right or in the front, and then you have that sort of predictability for it.
And the way to ensure that is that there's a flush port on the catheter, so you keep that at 3 o'clock when you're going in, and so usually you end up with,
so your... The newest version, FX Plus, actually, you can even rotate it when to get the commissural alignment. That will be, you will be able to, these ones you can't rotate them once you are there, but those ones you will be able to, like Asaad explained.
These ones you have to bring them back into the aorta and then
back in the aorta and then you rotate them, where these ones you can't actually. So.
All right, so we're pretty happy with the position. So we use 50-50 contrast for our injections to try to minimize the contrast. That's why the dye amount is not a lot. So at 2/3 deployment, this is kind of where we ended up. So what does everyone think?
So one thing we forgot about was the parallax. Yesterday we had a very long discussion. Everything else went into the background and we kept discussing parallax. So parallax भी इन्होंने Dr. Usman ने remove किया है, but what we discussed was कि parallax जो आप start में remove करते हैं, that is just for the initial 1/3. After the initial 1/3, you have to realign it to see the position and stuff, because the parallax has to be removed again. उस्मान एक जरा पिछले पे आप जरा पैडलेक्स वाला भी इनको दिखा दो कि how you removed it.
Which one? पिछली slide?
पिछली.
I think he didn't store the. There is it.
कि remember we were talking yesterday me and Ali कि इस पे बहुत ज़्यादा discussion की ज़रूरत नहीं है क्योंकि you will learn it as you go along. But the bottom part of it should not look like a circle. It should look like a flat line कि they are behind each other for you to start deploying this valve.
See, I think in your initial experience, when you guys start doing this, this parallax is going to be a term out there. But, you know, this cusp overlap has made life really easy. You start deploying the valve, the non-coronary cusp is the deepest most. So, you know, if you got the non-coronary cusp, automatically you have the other two cusps. Okay, so in the cusp overlap, if you are at or below the non-coronary, you don't have to worry about parallax because that's where you started deploying the valve. And then in LAO and extreme LAO, you get rid of complete parallax. And on that, if it looks deeper, it doesn't matter because you've already confirmed in your cusp overlap view that you did indeed get the non-coronary.
I agree. So it's become less of an issue with time. I will just stay in my implant angle, go to 2/3 deployment, make sure patient is stable, and then change views, go to LAO, remove parallax, and then
I pretty
see
much
what
do
the
the
valve.
same, like, because my first contrast injection is pretty much when it is near to release. Actually, it's gone past the rumble. I don't take any injections before that.
And so interesting to note where this valve ended up. And remember this angle and look at this angle when we were positioning the valve. So there's always, you have to be able to kind of predict how the valve is going to sit and which way it's going to shift. And it's not always, you can't always predict it, but you know, it helps in your valve positioning.
So one thing I would do different, Usman Bhai, is, you know, when you're releasing, I really bring the wire all the way inside the nose cone, so the nose cone essentially has no wire hanging out. And that ensures that you really have a lot of tension and the valve is really not going to pop out.
Right.
Once you have that nice loop inside the LV, you don't really know what kind of forces, what kind of a mechanical conflict exists inside the system. So I think just pulling it all the way, the nose cone centers all the way, and then you release your pedals.
Yeah, I learned that when I went to UK to do that, actually, that was in Canada when I was doing it. He said, if it pops out, everything will pop out with you. So they were a bit hairy about doing that. But yes, you're very right that you have to release the tension from it. And I think this is the phase where you have to just give them as much time as you can and let the torque get out of the system, so then it will move here less.
So I do pull the wire back, but not aggressively. And then we do a very slow deployment. I pace through the deployment, and there's a lot of forward force on the catheter.
You do pace through the deployment. So that's your protection, right?
Yeah. The pigtail is jailed, so you are not worried that while pulling it, it may. Pigtail is basically jailed while deployed.
It usually comes out. There's no issue with the pigtail.
A lot of us take it out before. Some people leave it in. Yeah.
Is it needed? Is it needed to jail it, or it's not needed? Yes. Then you take it out.
You make a good point. See, the issue is sinuses are big. Now, let's just say you were putting a 23 and the sinuses were building 25. It gets really hard. Sometimes it's impossible to get an IVUS catheter across the stent frame.
Yeah.
So yes, the sinuses are huge. You're at 34, 35, so I don't think jailing is an issue here.
Yeah. And sometimes if you can't pull the pigtail back, I just wire it out. It's never been a huge issue. So we were left with mild PVL in this case, and we decided not to post-dilate. The patient was stable. And the hemodynamics, the post-hemodynamics didn't suggest significant AI, so we left it at that.
So Ali, what's the depth of deployment here? Is it 3, is it 4, is it 6? What is the depth of deployment? So why don't you walk the crowd over how you would assess the depth of deployment?
So the length which I measured, the first nodal should be around, if I say that it's around 4 millimeters, and that's because the first crown is always bigger, 8 millimeter, and then the rest becomes all 6 millimeters. The first nodal distance is 4 millimeter. So you check it with the nodal distance, but at this time, even if you check it or don't check it, it doesn't matter because it's gone now. So My checking point is that 2/3 deployment where I can recapture it. After this, I don't even check it because it just makes me unhappy if it is too low. Sir, so that's a very good point. There is some paravalvular leak there, but believe me, this will disappear in 10 minutes, I think. And then in a month's time or something, it will have reshaped altogether and it will be completely gone. So mild paravalvular leak, leave it. This is to be handled, okay. So if it is severe paravalvular leak, then obviously you have to wait, see it becomes moderate-ish or not. If it is severe, after 10 minutes, still severe, you have to do something. You have to post-dill this valve first and then check it. After that, you see it again. If it is still there, then you can think of, okay, I'm going to put another valve through it or whether I should cover it up. If it's still there, then you can plug it as well. So, but majority of these valves, if the patient is a bit older patients which we get at the moment and they have got a mild to moderate-ish paravalvular leak, I accept that and just take it off and send them.
I think the mechanism matters. If the mechanism is dense calcification eccentric at the annulus, then you can post-dilate it, but if you're too aggressive, then you can run into other catastrophic issues like annular disruption.
You have to balance this post-dilatation with it. You have to see, I would say, I would leave a moderate paravalvular leak, then popping out of this valve. So it's a balance between the things which you have to achieve. So.
The best thing is to increase your Nyquist limit so moderate looks like trivial.
Don't take a shot. Just tell the echo guy to do it.
Since we removed the echocardiographers from the room, we've never had moderate or severe paravalvular leak. It's always mild.
Yeah, but I think the bottom line is, what's the cause of it? If there is LVOT calcium, and if you know there's no LVOT calcium and your depth is good, this will go away, as Ali said. Even if it's moderate, you won't worry about it.
See, one thing, especially if you're putting large frames, it's very important to do a sweep like 360. I go RAO caudal to LAO caudal, RAO cranial to LAO cranial, just to see there's no enfolding. Because understand, enfolding...
For bicuspids,
yes, that could be the nidus where all the PVL is coming out of.
So I've got a question. If it's enfolding, what will you guys do? Post-dill it. Is that correct? Do you guys think post-dill get rid of enfolding or not?
Most cases, yes.
Yeah, again, the mechanism, but if there's not a lot of, if it's bicuspid and you're really oversized, the enfolding is not going to get that much better.
What I do is that I do that sweep before releasing the valve. If I find the enfolding, I never go ahead and deploy that valve because I've seen it like, others I would remember with the case we were doing in a workshop. And this enfolding is a bad business actually, which my feeling is. So see it before, then afterwards, and make yourself unhappy. I think that's what.
No, see, Ali, the issue is this. The issue is, I recently had a case just last week. BAV, we did BAV, patient goes into wide open AI. He opens his mouth, he gets intubated, and then literally we deployed the valve in a matter of seconds. You don't have time because literally this patient, his lungs are drowned now. This folding and folding doesn't matter. You have to put the valve to get rid of the AI.
We had the same case when we were doing Basilica, but that was good because the patient was in cardiac arrest and you did it so good. You did it so quickly, nothing was moving and the valve deployed so well and he improved so quickly after that. So yeah, sometimes it's good.
Just one thing about the audience, like Professor Bilal Saab's question was so relevant. Kyun? Paravalvular leak is one of the things that has shown a significant mortality disadvantage for these, and the reason is that these ventricles are very hypertrophied. There's not much space in them, and if you induce AR in them, they have been tolerating AS for a very long time. Now if you induce volume overload in them, it's a pressure overload system, and you have added another problem with it. So they won't live too long with that.
So if these patients have on the start a bit of AR, I'm happy to see that because I know that they will tolerate some paravalvular leak. Imagine if they don't have any AR, like Asaad mentioned it very correctly, this physiology of it, then you can get in trouble actually. So.
And that's where your pre-BAV and pre-valve hemodynamics matter. So you look at the LVDP really well because you can compare it with your post-deployment, and if that's going up, your pulse pressure is reduced. Even if on echo or angio, your AI doesn't look that bad, but the hemodynamics suggests that it's significant, then you want to really carefully assess the valve.
have this AR, are you more prone to infective endocarditis after that? That's the next part that comes after it.
I will let Asad answer this question.
I don't know of any of that data because what you are referring to is patients with AR who are more prone to infective endocarditis because of defective leaflets. So here the problem is not defective leaflets, it's the frame is a bit either infolded or whatever the anatomy is. So I don't think there will be a high likelihood. I don't know if anybody else knows anything.
But then again, you're very right, it's an important matter related to mortality.
I'm Dr. Atif Sher from NICVD. I want to make two comments. One is about the peripherals. It's not only about the calcium, but rather the distribution of calcium. If it's circumferential, then it definitely becomes more difficult, leading to more vascular access complications. Secondly, I just want to ask you one thing, that to the best of my understanding, the coplanar view is a CD-based. And isn't it a false impression that all the three cusps are at the same level? Actually, it doesn't happen. So probably the cusp overlap view is a better option now. That's what I feel. And a question that I want to ask you is that if you have to select among the three super stiff wires, that's the implants, Confida, or the Landerquist, which one would you go for?
So
Thank you.
I will just answer this coplanar view and things. This is music to my ears because I spoke to Nicola Piazza, and where is Salman? I think he's here somewhere. So this is completely, your valve plane is never ever the same as when you're deploying it when you did the CT. The patient was lying like this, everything was different. This is completely, I think, I do not rely on this at all. I think that this is a illusion which we have created in our brain about it. Go to the two-cusp view, just straight away check it. If you're okay with it, just go with it, check with the parallax, and then later on do it. That's my, I think these are very strong words from you because we work on a lot on the app of this system which we use during our deployment. It takes a little bit of time, but then it helps you in deciding which is the best view for it. But then I agree with that. The next question, wire selection.
Wire selection, I think we do 99% of our cases with Confida. Yesterday we explained it in the training village as well. Okay, when I started doing it in late 2014 and stuff, these Confidas and Safari wires were not there, which were preformed. We had to make these bends, and I was telling them yesterday that I was a fellow, and fellow की job ये थी कि वो consultant bend बना के आपको देता था, and we were just pressing it for 5 minutes to make sure that the bent part, which is going to hit the ventricle, there is no actual spicule in it of anything pointing out because it's a man-made bend. And the other part with it is that if you are manipulating that wire which has a bend made by you, after a few manipulations that bend would go away and then you end up with a very stiff wire hitting your ventricle. So Confida wire, which is pre-shaped, I think is pretty good for 99% of the cases. We use Landerquist, which is the stiffest wire we have for cases like where you have a horizontal aorta, valve-in-valve case, or sometimes if your peripherals are very stiff, you try to get your valve up with that.
Gada, who's one of the big proponents of cusp overlap, he's like, use Landerquist for all your cases because you get much better, I guess with the cost issue or non-availability of Landerquist.
No, I think Landerquist and Confida price is the same. It's the non-availability in Pakistan.
I think for most of your cases, pick a wire that you're comfortable with. But what Asad is saying, that the super stiff and extra stiff wire doesn't come pre-shaped and you're going to put your bend on it, I think we've all moved away from that because there is a risk of leaving a little bit of an angle there that can damage the LV. But otherwise, either use a Confida, Safari, or a Landerquist. We use a Confida because it's easily available.
Yeah, Confida is easily available. Other stiff wire, I only use it if the aorta is a bit out of shape and I want to bring it into the shape. Yes, it's cumbersome. Make it easy for yourself and use Confida probably at the moment. So, thank you.
So we have to wrap it up.
I think we'll wrap it up. We went a few minutes over, but great discussion, and thank you to everyone.
Thank you so much, and it's good to see so many people in structural heart. So that's so encouraging. I think it's very good. Okay, thank you so much.
Hello, Hello. Now we will be having a lunch.
We don't have lunch. We have just a brief lunch symposium on heart failure. So just stay here. After that, you will be having lunch.
Okay, yeah, that's what I was going to tell. Now we'll be having a lunch symposium here, a brief by Tabros. After that, the lunch for the faculty will be served at the Dastarkhan, that is the morning breakfast area. And for the rest of the attendees, you go out, take left and right, and then it will be at Shamiana for all of the attendees lunch. So please be seated for this lunch symposium. Thank you. Over to you, Fuad.
Thank you, sir. And without wasting any further time, I will request first the panelists to take their seats. And we have panelists of this session, Professor Tahir Saghir, sir, Professor Tariq Abbas, Professor Zubair Akram, sir. And we have few more panelists which are waiting there in other session. Whenever they join, we'll ask them to join us on the podium. And with that, I think let's think to be settled. ये greeting और मिलने मिलाने का सिलसिला अगर ये जो ईद मिलन चल रही है, अगर इसको हम थोड़ा सा सेटल कर लें, कहीं बैठ जाएं या बाहर चले जाएं, आराम से मिल मिला लें, so that we can start our. Certainly, we are switching gears from intervention to medical treatment, and especially medical treatment in relation to heart failure. We all know that heart failure management is all about fine-tuning of medical treatment. And nowadays, we are going away from that in a way that proper assessment, proper management, which drug to be used, in what stage of disease, और उस पे मुझे एक शेर भी याद आ रहा है, कोई क्या किसी का लुभाए दिल, कोई क्यों किसी से लगाए दिल, वो जो बेचते थे दवाए दिल, वो दुकान अपनी बढ़ा गए. तो अब वो दवाइयों वाले मामलात रहे नहीं हैं. वी आर ऑल इंटरेस्टेड इन मैनेजिंग एंड इंटरवीनिंग. सो लेट्स, ये भाई पीछे भाई साहब ये हमारी जो है ना, ये मिलने मिलाने में ही 15 मिनट गुजर जाएंगे. कैन एनीवन जस्ट मेक द थिंग सेटल डाउन? So I think let's move on to presenting. जी, बस इसके बाद फिर आप जब presentation शुरू हो जाएगी तो रोक दीजिए. So now I'll request the presenter of today's session, and I hope he will restrict his talk to 10-15 minutes so that we can have discussion with our experts, so to make the session more lively. Professor Bilal Mohyuddin. ज़िया मोहिउद्दीन के बाद बोलने में जो सबसे एक्सपर्ट हैं वो बिलाल मोहिउद्दीन है, जिनको रोकना है, जिनका मुकाबला करना बड़ा मुश्किल होता है. So I hope he may restrict himself to 10 to 15 minutes. Sir, over to you.
आज कहानी फर्क है.
Over to you.
आज कहानी फर्क है. आज कहानी मैंने नहीं बोलना. आज
एक शेर आप पे भी बोल देता हूँ.
बोल दे.
शोला सा लपक जाए है आवाज उस गैरत नाहीद की हर तान है दीपक, शोला सा लपक जाए है आवाज़ तो देखो. अब आवाज़ सुने आप इनकी.
मेहरबानी. अच्छा, माइक्स है यहाँ पे? हर एक के पास माइक्स है अपने अंदर यहाँ पे? क्योंकि मेरा ख्याल है कि ये जो टॉपिक जिस पे मैं हाथ छेड़ रहा हूँ, ये हम सबको पता है. और इस पे छेड़ने से पहले जो चीज़ आज लर्निंग के हवाले से है, वो ये नहीं है कि ये आर्नी कोई नई चीज़ आ गई है या कोई और चीज़ इस तरह से आ गई है. आपको पानी चाहिए जुबैर सर? माइक ऊपर कर दूं? अब ठीक है? ओके. सो व्हाट आई वुड लाइक इज दैट बिफोर आई स्टार्ट ऑफ, एंड आई एम गोइंग टू बी वेरी क्विक एंड ब्रीफ, बट बिफोर आई स्टार्ट ऑफ, मे आई आस्क, I'll point this pointer at everyone, and I'm going to ask them the simplest question on God's earth. If a patient comes to you with heart failure, what is your first step? Sir? इधर mic दे दो यार. इधर mic दे दो. What is the first step if a patient comes to you with heart failure? On कर दे यार, mic अच्छा होता है.
वाइटल्स इसकी देखनी है हमने सबसे पहले, पल्स, ब्लड प्रेशर, ऑक्सीजन सेचुरेशन एंड ऑक्सीजन, और आईवी लाइन को मेंटेन करना है इसका.
Right. So we have presumed that this patient of heart failure that you normally presume a heart failure is, it's a person who requires aggressive management. ठीक है जी. Sir, ये वाला, काशिफ साहब, how many patients of heart failure are coming to your practice? सर आपके बाद अभी आ रहा हूँ, पहले ये वाला फिर आप वाला, आप दोनों काशिफ हो बेटा कर. चलो जी, माइक्स इधर, बेटा ये माइक ले लो इधर और माइक लेके फिरते जाओ.
सर हमारे 10-15 मिनट तो इसी में गुजर जाएंगे.
सर यही टॉक है.
सर लेट्स,
आपकी डिस्कशन में मैं साथ ही निबेड़ रहा हूँ.
सर अगर आप मॉडरेशन का रोल भी आप ही करेंगे
जी सर, तुझे समझते हो आज ताड़ा काम पूरा हो गया. हाँ जी.
In MIC Multan, the outdoor patient daily coming to us is 1500 patients daily coming to outdoor. Out of that, around 150 to 200 are of heart failure.
Out of 150, so
out of 1500.
1500 patients. How many?
Around 150.
So 10% patients are in heart failure.
Yeah.
The second kashif over there. 30%?
20% or so.
Right. Tariq Abbas, what is your percentage of heart failure coming because of valvular diseases?
It depends upon the definition of heart failure. If you take in a broader term, heart failure, what we took as a heart failure is a very high, very patient with very high symptoms and very low EF. We consider them as a heart failure, but heart failure starts from after MI, reduced ejection fraction, preserved ejection fraction, or ejection fraction is mildly reduced. It's a huge range of heart failure now. And considering all these definitions, we think every patient is a heart failure patient now.
And actually, you can't say the patient presenting with heart failure. Usually present with symptoms suggestive of heart failure rather than heart failure. It's you who work out and diagnose whether he is having heart failure or not, and considering the fact heart failure, HFpEF, HFrEF, marginally reduced EF, stage A heart failure, diabetes, hypertension, everything. So ultimately,
Sir,
you end up with 90-95% of patient heart failure.
match chalega. Okay, so I'm, ये चलता है? I'm, कहाँ पहुँच जाइए? That's me, and Bismillahirrahmanirrahim, and of course the disclosure is that this is a sponsored talk, so a lot of these slides have been helped by TAVR, and all of us are together. This is the global burden, they say. Do you agree with this global burden? You see, it says so many millions. Do you think this is an overestimation, underestimation? Of course, we don't have our figures, but our generalized figure coming from Punjab Institute of Cardiology is this, that I receive roughly about anything between 8 to 100 to 1,000 patients in our emergency daily. Out of these, only about 20 or 25 are acute MI, or 40 at the most. My maximum primaries in a single day has been about 23, 24. Usually we do about 12 a day and about another 15 SKs because there are repeat presentations for some problem. Rest of them all are coming in and going out, and nearly about 100 of these patients that are retained are in heart failure. And this heart failure business, I won't be surprised if this figure actually is an underestimation, because these figures are growing worse day by day. This is the flow that they say the world has. 26 million I wonder with this 5 billion of population, if they say 26 million, then it's probably not that bad a figure. But the figures are probably far more high than what actually seems. A lot of these parts of the world currently do not have a health system which guides us properly, and neither does our country at the moment have that kind of a health system. A few of these countries, these are the figures that they say are over there at the moment, but their economic burden is extremely high. Of course, the global burden, the prevalence, the incidence, the mortality, all are on the way up. And of course, the biggest problem is the cost. Now, as far as the cost is concerned, we are at a total clear-cut loss of what the true cost is. The true cost comes of the cost that a family has to pay. किसी और को स्टेज पे चढ़ाना है वो भी चढ़ा लो, मैं उतनी देर चुप हो जाता हूँ. A true cost only comes from the fact that what is the family cost that it comes to. The family cost comes from the fact that today, currently, in our way of life, when one person gets admitted, 2 or 3 family members are also inclined to stay with them. And that is the other cost that you will never see. How many other people lose their jobs because a loved one is admitted in a hospital? Of course, it depends on which class you are, and the class that you are in, that is the amount of exercise that you can do. May I ask a simple question from all of you friends? How many of you are able to carry out a 6-minute walk test prior to starting the treatment and then following it up with some very basic investigation? Bashir Hanif Saab? Bashir Hanif Saab? Haji, how many of you are able to do a 6-minute walk test prior to starting a heart failure management? Because in Taba, I know you have a plan.
We do have an excellent rehab program, and over there, all patients, heart failure patients, go to rehab, and they do get 6-minute walk test over there.
No, sir.
We have marked the area, and they do that in every patient.
So do you do a pre, a midway, and a 6-monthly analysis of their 6-minute walk tests?
No, we don't. We definitely don't do 6 monthly. But when the patient is admitted or comes in the clinic, I do refer them for rehab, and then whenever they go to rehab, they do the 6-minute walk test.
Zubair Saab, do you think they should have a periodic 6-minute walk evaluations?
It's not available actually everywhere, and nobody has time. We don't do it, but we just go on clinical. First of all, we see what are the risk factors involved, whether there are pre-existing risk factors to cause a heart failure. But as Fawad was telling, obviously, it's the dyspnea which alarms us, and out of proportion dyspnea, and then we go with all sorts of...
But doing a 6-minute walk test is no big deal. It's
yeah, I know, but maybe we don't have, at least we don't do it as a protocol.
So, do you think there is any significance of having this thing? Tariq Abbas? A 6-minute walk test. Is there any significance? Because we are always talking about the functionality improvement later on.
I don't think so that we should have this regularly, but the symptomatic improvement is there if patient, and but for the quantification or for certain reason, if you want to quantify a certain treatment, whether patient is having 6-minute walk test before and after the treatment, then it will be okay. But as a general well-being, it is okay. Then you can have assessment in the improvement of the patient.
Harun sir, you were there. Mike sir ke paas Harun sir paas aage liya. Do you think a 6-minute walk test needs to be put in? This should be a mandatory part of starting off a treatment, at least in a clinical, in a tertiary care hospital.
Yes, Bilal, I think I agree with you. Because there should be some subjective test. Like, of course, you are seeing the patient symptomatically, but if you are doing this 6-minute exercise test, you will be assessing it more precisely. And these are the, I think, guidelines as well, and the hospitals do it.
So that's what I was trying to come to. Mansoor Saab, please mic over there. Oh, Pisha, oh, hero. ओ इधर 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 सर ये इधर 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 इधर
Thank you so much, Bilal. Rest assured, my philosophy for any treatment is to keep the patient mobile. I will not allow any patient in bed, even in their CCU. They must be sit out in the chair. So when you do exercise test, what you are doing, number one, you are objectively assessing him. Number two, more importantly, it gives patient so much confidence that he can do it. Because at home, he says, सांस फूल जाता है, घर वाले कहते हैं आराम करो, और आराम करना means you are asking for the end. So I think it's most important that we should have some sort of assessment, not only for yourself, but for patient also. When I send them for exercise test, most of the doctors, they refuse कि तुम्हारा सांस फूलता है, which is very funny. Do it as per their limit, and when they come back, when I see the result, I said, देखो तुमने इतना किया, तुम तो कहते हो नहीं चलते. It really is a wonderful thing to do it, and we must all learn to do it. It helps both ways, for patient as well as us.
Sir, on an anecdotal part of the same thing, a patient comes to me from a dear friend's referral, and that she's not well at all. A whole flight of investigations are available which say everything is honky-donkey okay, but she's totally disturbed, and she insists that I cannot do any exercise, things go wrong. So I sent her off for the 6-minute walk test. She has a relatively high BP, 160. She starts doing her walk, and the blood pressure starts settling down. Because that anxiety part, the moment she sees that there's people around you, things are being supportive, so they start moving well. So that is the reason why this has to be done. Of course, this is a whole array of way in which we evaluate our patients. Of course, the classifications of the heart failure, that it has to be 40%, etc. We all know these slides more than enough many times. Of course, the stage A, where you are still quite comfortable, stage B, when things are going on the wrong side, and this is the time when you need to become proactive. Because once the things start going wrong, that is the time that actually we have lost it. So if you are at stage A, get active, and if you are hitting the stage B, that is the time that you should make sure that your patients are aggressively managed. Because once you start hitting stage C or D, you have actually lost the battle. All that you may be able to add on is a couple of years, something over there. You have a patient who actually comes in, and you are surprised and happy that they have walked out of your clinic because they're that bad dyspnea. And then after a couple of months, they again come back in. But when you do an echocardiogram, you know that ejection fraction is down to 15, 20%, hardly anything happening over there. And then a few months down, everything goes. So from an interventionist point of view, if you are not going to be aggressive enough, then you are not going to be doing the correct thing. That is the whole idea behind all of these management things. Of course, these are the trajectories in which the class C1 drifting away. These are the various parameters that I'm sure you have seen many times in various slides. The fact that so many of them die suddenly, the heart failure, and die with other causes, these are statistical analysis that you come up with. But as far as finally the whole thing is concerned, luckily now things are improving, but still plenty of deaths do happen. And unless you know aggressively what it is, the problem, unfortunately, lies from the fact that when we start looking into all of these angles of treatment and the various favorable factors and unfavorable factors, we start focusing on the pharmacological therapy. And when we are focusing on the pharmacological therapy, we actually forget the basic lifestyle that a heart failure patient must have. If you have a heart failure patient who insists on smoking, who insists on not doing exercise, who insists on maintaining bad blood sugar levels, no matter what kind of a treatments you come up with, he is never going to stabilize or she are going to go down. How many of you, may I ask, are the ones who would not start a treatment or would insist in their follow-up with good 10 minutes of discussion regarding their smoking habits. Professor Nadeem Saab, Hanji, since you are busy discussing, I thought that I'll ask you this question, that how many of times do you sit down with your patient and inquire about their tobacco consumption?
सिवाय एंजियोप्लास्टी के ना मैं टोटली निकम्मा. Got three B's in my A level, तो इसलिए मुझसे कोई एकेडमिक चीज़ ना पूछो. सिवाय एंजियोप्लास्टी.
फिर भी पूछना था, आपका एंजियोप्लास्टी होती है, आप उसके स्मोकिंग अलाउ करते हैं उसको बाद में?
I think a good serious question. I think person who's smoking more than 10 cigarettes a day for more than 10 years, it's going to take 1 to 1.5 years before if lag effects, you know. So there's no point in stopping. ACS के अंदर immediately कभी भी कोई smoker को आप बंद नहीं कराते हैं, because उसमें जो thrombogenicity और जो rebound catecholamic release है वो ज़्यादा होती है. तो डिस्पाइट दैट फैक्ट वी कांट ऑफिशियली टेल दैट, लेकिन मैं नहीं बंद कराता. मैं कहता हूँ जी 10% पर मंथ या इस तरह करके आप अगले 2-3 महीने में स्मोकिंग छोड़ दें.
So do you agree with Professor Nadeem's statement that who is a smoker, he should not quit smoking?
No. Post ACS, post MI या ACS का patient, when you do an angioplasty, if he's smoking till the day of angioplasty, there's no point in telling कि कल से बंद कर दो.
जी सर, you look excited. इधर लाओ माइक. इधर. He looks excited.
I differ with that. I tell my patient to stop right away, and I check with every time they come to the clinic to see if there is a smoker. I have written in the problem list that he's a smoker, and I make sure that I check with them whether they are smoking or restarted smoking, and they have to stop it. I keep very strict about smoking.
सर, पाकिस्तान सोसाइटी ऑफ इंटरनेशनल कार्डियोलॉजी के जनरल सेक्रेटरी साहब नीचे सर फेंक के बैठे हुए हैं.
कोई डेटा है आपके पास कंपेयर टू कि जिनको फॉरेन स्मोकिंग बंद की या जिनको विद इन 6 मंथ्स बंद की तो लॉन्ग टर्म मोर्टेलिटी मॉर्बिडिटी पे या रिकरेंस पे कोई चांस है आपके पास डेटा?
ये डेटा डेफिनेटली है कि इमीडिएट स्मोकिंग सेसेशन वर्सेस ओवर लॉन्ग टाइम सक्सेस ज़्यादा ये है कि कोल्ड टर्की क्विट करना ज़्यादा आसान है बजाय स्लोली करना जो है.
डेफिनेटली स्मोकिंग के साथ जो टोबैको चुइंग और निस्वार ये सारी चीज़ें भी आप कोरिलेट करें, डेफिनेटली इनको बंद होना चाहिए. उसके लिए आमतौर पे एक तो ये कि आप स्ट्रेट फॉरवर्ड बोल दें कि बंद कर दें, दूसरा ये कि टेपर डाउन कर लें और उनको टाइम लाइन दे दें कि इतने अरसे में कर लें. थर्ड, मैं आमतौर पे उनसे फरमाइश करता हूँ कि आप जो सिगरेट पीते हैं डेली उसके सेब खाया करें, तो वो उससे थोड़ा सा वो लाइटली ले भी लेते हैं चीज़ों को, मगर जिसने बंद करनी होती है ना वो हार्ट अटैक के बाद ही बंद करता है, उससे पहले बहुत कम बंद करता है.
लेकिन this is very surprising rather, at least for me or for whole of except जो रिजवी साहब ने बात की, कैसे कह सकते हैं कि एंजियोप्लास्टी हुई है 2-3 दिन एक सिगरेट पियो, तो मतलब दिस इज अ न्यू कॉन्सेप्ट. आई डोंट नो कि वेदर वी हैव हर्ड ऑफ दिस और नॉट.
नहीं, वो यू राइट. देखिए, ये तो कोई भी नहीं कह रहा कि स्मोकिंग करें या ना करें. मैं आपको प्रैक्टिकलिटीज़ की बात, देयर इज़ नो पॉइंट, वी हैव टू फर्स्ट एक्सेप्ट द रियलिटीज़. आप या तो यहाँ इंग्लैंड की तरह या कनाडा की तरह फॉलोअप्स हों. आप कितने पेशेंट जिनको आप कहते हैं कि स्मोकिंग फ़ौरन बंद कर दो, बंद करते हैं, लेकिन एटलीस्ट अगर वो झूठ बोले आप ना बोलें, एटलीस्ट दैट्स बेटर.
हाउ मेनी ऑफ यू प्रोएक्टिवली स्टॉप स्मोकिंग? आस्क द पेशेंट टू स्टॉप. प्रोएक्टिव.
They must. Bilal, I'm sorry if you don't mind. Actually, the time is short. We have to start the next
session. Sir, जी आपने मेरे 20 मिनट आपने खा लिए में.
15 मिनट की बात थी तो प्लीज आप अगर क्वेश्चन कम करके इस पे बात कर लें क्विकली, अदरवाइज डिफिकल्ट.
That is the whole thing about it. आगे कोई ऐसी चीज नहीं है.
फिर बशीर कोई प्रोवोकेटिव टॉपिक ना रखा करो.
The topic was
कोई भी टॉपिक होगा तो बिलाल उसको प्रोलिफिक टॉपिक बना देंगे.
Role of ARNI in heart failure, and what we are discussing, everything of heart failure except ARNI.
Then एक second, Farooq, we are over here for patients management. We are not over here for our knees. Let us be very clear.
You can speak volumes about heart failure.
No. Idea is that what I have been practicing and what I have been seeing, I'm just getting into that.
You can arrange
Let's have the opinion from Dr. Saab over there.
Heart failure or 2-day symposium for heart failure, no doubt.
एक practical बात बता दो कि we are working in FIC. अभी सर जो बात कर रहे थे कि you can't stop smoking, अगर acute events के साथ patient आ जाता है, he has been admitted for 4-5 days, तो मैं उसको अलाउ कर दो कि नेक्स्ट 24 आवर में हॉस्पिटल के अंदर वो सिगरेट पिए.
Excuse me, we have session starting right at 2 o'clock.
Okay, so I'll quickly wind it up for you.
May I request you to just wrap up within the next 5 minutes so that people have time to have lunch and then start the sessions.
This is your angiotensin By the way, Zubair Sahab, I was supposed to start at 1 o'clock. You took out 20 minutes from my session.
I know.
So actually, you owe me 20 minutes.
Okay.
So let's be clear as far as that part is concerned.
लेकिन सॉरी बिलाल, ये क्लियर इंडिकेशन इन लोगों को दी गई थी कंपनी वालों को भी कि 15 मिनट की टॉक होगी, उसके बाद
15 मिनट ही हो रहा है, 15 मिनट ही हो रहा
This is
है.
what we
These
told
are the
them.
5 pillars now reduced to 4. Are you considering that these are the only pillars, or do you want to add into it? Do you think anything like statins should be added into it? Do you think anything like NOACs should be added into it? That's a debate that always comes up whenever you're discussing a heart failure management. Of course, neprilysin, etc., they have all come up with various facts, etc. It helps to decrease the symptoms. And the paradigm trials were all there, and we have all seen these things many a times. This is the way in which you have enrolled your patients. You all are clear about this, I'm sure. The fact is that you have to treat 21 patients, and then something of benefit is going to be seen. It is this big figure that you have to keep in mind, that this has to happen. So for you to get your patients down, this has to happen. Similarly, over here, according to the primary endpoint of the death, 32 have to be treated. Similarly, over here, 36, and the time to hospitalization, another 30 days, you have to bring it down. If you start taking your treatment, you start improving immediately, and half of them improve immediately. Summary of efficiency comes from the fact that if you are doing this, nearly 20% reduced cardiovascular deaths happen, 20% reduced in mortality happens, 21% reduced in heart failure happens, and fewer heart failure symptoms and a better quality of life comes in. Of course, these are the where permanent drug side continuation comes in. Nice technology prices says that NYHA class 2 to 4 as importance, who are already taking stable ACE or ARB, they have to be given. And with left atrial ejection fraction less, you must add on these treatments. So don't wait for LVs to go down. Treatment with segmentable vasodilator. Do you agree with this thing that a patient should only come to a specialty hospital, and only specialty hospitals are allowed to start this treatment? This is a debatable question which are there always. Of course, these are the lines in which we manage our patients. You may have a stepwise approach, and you can accordingly decide either go with each drug to a maximum or keep on adding them. Every medicine has its own specific effect, and that is the way the patients improve. Step 1 medicines may be started simultaneously. These are the various ways in which you are able to improve your patients. Remember that diuretics today are the only ones which are in the class 1, though the levels are all C. But class 1 is only with them. Rest of them are coming up, and segmental valsartan yet are coming up, may be considered. Everyone has their own set of advantage and has been defined clearly. Again, the treatment for preserved ejection fraction, these are the things which must be done. Heart failure with reduced ejection fraction and with preserved ACE, question mark, betas are common, mineralocorticoids are common, and segmental valsartan is common. Other two, these are a debatable thing. Prognosis, annual mortality rate depends on a patient's symptoms and LV function. 5% in patients with mild symptoms and a mild decrease in LV function. 30 to 50% in patients with advanced LV dysfunction and severe symptoms. 40 to 50% of death is due to sudden cardiac. Again, the various ways of treating and initiating the treatment. Summary, NYHA subjects must be started off, maybe on low dose of ACE or ARBs, and then you start moving up. So with that, I'll say thank you, and this is the message from Debestro by our friends, the TAVRs, who are one of the major sponsors of this conference. And if there are any questions or any ideas.
Thank you, sir.
Auji.
1, 2 final concluding comments, and then we'll end the session. If the audience have any questions, we can take. Yes, Kaleem, quick.
decompensated steroid, is there any role of ARNI present in this population or not?
So you're asking about if a patient has had an MI and is decompensated.
It's just MI or any heart failure. It's any heart failure with just class NYHA 1. Is ARNI indicated, or you go with your conventional ACE or ARBs?
I'm simplifying it. Patient presented with 30% ejection fraction with NYHA1 symptoms. Can ARNI been given or not?
I showed that slide over there. It said that in the earlier cases, there is a role. So in the earlier patient, the earlier you start it off, the more benefit the patient may get.
The guideline said present recommended NYHA 2 and 3 symptoms with reduced ejection fraction. It's a class 1 recommendation. Someone presented with decompensated heart failure, NYHA 4 symptoms. Can ARNI be given in this population, or we have to start AC inhibitors and then switch to ARNI?
As far as starting off with ACE inhibitors and then switching to ARNI, it has been clearly been seen as far as the enalapril is concerned that this salt is superior. So you get a better result as far as that is concerned. As far as that is concerned, it is not an end-to-end, and that comparative analysis was not against a placebo, it was against a proper medicine. And that the original heart failure in which there was only valsartan, there was benefit over there also. So all these medicines, as far as heart failure business comes in, no matter whatever is your predisposing reason, it is of benefit.
But I think as a general, you can use, although guidelines are suggesting 2 to 4. I agree. HA new guidelines, they are suggesting 2 to 4 NYHA. Yes, any concluding remarks?
I have a question. I have a question, sir.
Where?
Sir. Okay, sir, my question is this dapagliflozin and EMPA, this has been turning into statins. Like statins had a lot of these effects. Now this DEPA from endocrinology colleagues, they are doing it for CKD, heart failure. How many of you, I mean at what percentage, you people are using dapagliflozin without diabetes in patient with heart failure?
It's indicated as a class 1 indication in HFrEF.
With diabetes.
Without diabetes,
it is type
even
class
without
2A.
diabetes, SGLT2, as we have seen the 4 pillar, so SGLT2 are there for HFrEF as class 1, whether you have diabetes or not.
Yes.
Your question
even
is...
in HFpEF and marginally reduced AF, it's 2A, superior to all other. So that's the spectrum.
I'm not sure. I think with diabetes it is class 1. Without diabetes it is class 2A. But if
no. I think you're wrong.
Okay, sir. Okay.
It's class 1.
Sir,
if
if the basic effect is diuresis, we have better diuretics like metolazone.
It's not basic effect of diuresis. It has multi-purpose function.
Don't know.
There are a lot of function which we don't know at all. And this is not a kind of diuresis of furosemide. It's an interstitial kind of diuresis, slow, progressive change in volume status. It doesn't lead to just passage of fluid as you have with furosemide. So it's not kind of that diuresis. Otherwise, it has disease-modifying effect, not at just heart level, at kidney and all other. So there are multi-purpose function of this SGLT2. I think we are running short of time.
Just one question.
I'll just add to your answer. I'll just add to your answer that the main things that it does is, it causes diuresis, yes. It controls the electrolytes, right? And the most important thing is it helps to reduce the weight. So unlike other things, and it is in heart failure, that is your biggest problem. So you can say that this weight loss is because of the diuresis. No, it is over and above that thing that happens. It's the tissue management that comes.
Disease-modifying effect as well.
Yeah. Sir, what is your experience of this starting this combination, this ARNI? Because I have seen that over patients in Pakistan don't tolerate the dose which is recommended in the guidelines.
Okay.
What's your experience?
My experience, if you ask me, is that majority of my patients, like a lot of other friends, we are maintaining our patients on 50 milligrams twice a day only. Yes. A few of them make it to 100, and very rare, some goes to 200. The only difference that the way I practice medicine is that I do not follow the lines the way they recommend that you start increasing it every 2 weeks. My increase is far slower. It may be, the only problem is that these tablets that they come in, they say that they are non-divisible tablets. So that becomes a big challenge, that how you are going to do it. But at times you just keep on doing it that way. So you may start off from a low. My only thing is that I'll be constantly watching their blood pressures. And if the systolic blood pressure standing is above 100, I'm quite confident that he should be okay later on also. And if the systolic pressure standing is going below 100, I will not upsize the medicine. And if his urine problems starts to creep up, again, I will start doing it. So my initial creatinine evaluation is every month. And from there, I keep on moving forward.
I think since you're using a lot of medication which one way or the other affect hemodynamics. So out of 4, you have to choose according to the comorbidities and other, and where you get a chance to have adequate pressure with all other drugs, you certainly try to increment as much as possible.
And this is usually my 4th drug that I add, not my 1st, 2nd, or 3rd. This is the 4th drug that I add. So I've got my beta blockers on, I've got my diuretics on, I've got my statins and aspirins on, if there's a need something else, and then this medicine comes in.
I think you can't make a standardized rule for ARNI to be 4. It's all depend on patient to patient status and comorbidities, which drug to be first and which to be next and which to be third and which to be fourth. Sir, final concluding remarks.
Thank you very much, Fuad. We had a very little time to speak, I think. So it was a wonderful session, and obviously the role of ARNI in the management of heart failure, now there is no dispute. Obviously this is class 1 indication, first line drug, and it's the revolution in the treatment of heart failure, you know. Way back about 2-3 decades back, we have plenty of patients, as Bilal told, you know, lying in the hospitals for weeks and even for months, you know. But early initiation of this ARNI ahead of this beta blocker and Electron or whatsoever, along with this new revolution that is empagliflozin or dapagliflozin, you know, it has changed the scenario. And somebody was telling, you know, ejection fraction of 30 in functional class 1, you know, now we have a lot of patients whom we started with, they were in functional class 2 or 3. And with this ARNI and empagliflozin, you know, they are actually in class 1, and we should not stop the patients that they have gone into functional class 1 and, you know, it was traditionally 2 or 3, you know. They are the drugs for now and the future. They have just changed and revolutionized the treatment for heart failure. Thank you very much.
Sir, Dr.
And because of that, the new class has been added in which you have the improved heart failure trial also, the study also.
So now for the faculty, the lunch is there in Dastar Khan, and for the rest of the colleagues, you know, you go out, take left and right, it's at Shamiana. I would request to have a very quick lunch for 15 minutes because there will be live transmissions and very important international faculty speakers are lined up, for especially for Hall A, and Hall B, you know, will be taking up with the fellows course, and up there in all the Acclaim halls, 1, 2, 3, 4, there are hand-on sessions for Rota, TAVR and everything. So a lot of interesting stuff going on in the evening. Thank you very much.
Thank you, Bilal. Thank you, panelists. And thank you, Tabros, for arranging this seminar.